IV push. So IV push is you're getting checked off on this after the first exam. So, but you do have to know the IV push meds that are relevant to cardiac and GI. All right. So that'd be the two we talked about today. Were what? Yeah, H2RA and a PPI. So pantoprazole and cimetidine, right? So you have to know those ones inside out. Onset peak duration, I'm not going to test you on, but for side effects and you know how you give it, not how you give it, but how you you know, side effects basically, and which one is a PPI, where it works, the mechanism of action, those things are fair game, right? All right, so IV push. All right, so let's go next slide. All right, so IV push, it's also known as different names out there in the universe. So it's called direct IV, IV injection, IV bolus, or a direct IV push med, right? So an IV bolus, really just any medication is given fast, right? Usually IV push meds are given between 2 to 5 minutes, right? So if you can't figure out, can't find it anywhere, give it over 2 to 5 minutes. That's usually the default, so if you have to guess, okay? IV medication is given in 5 minutes or less. Why would you do this? Because they're NPO. They have an inflammatory bowel, they have a diverticulosis, and they're bleeding everywhere. You can't give anything PO to that patient, right? But they're complaining of GI bleeding, and you need to give something IV push, like to, I don't know, it's not terribly painful at that point, but if you had to give pain meds, for instance, you would give that IV push, right? Can you give pain meds, IV push? As a nursing student, no. As an RN, yes, right? So rather not get an IM injection. So you're giving IM, you know, antibiotic around, you know, twice a day. Well, I can give that IV push. I'll just switch it over from IM to IV push, right? It only comes in IV form. So like, for instance, like phenylephrine. Well, actually, that's a bad example. But you have a medication that's only IV push form. That's all you can get, right? And there isn't a PO version. What else? We got it's faster onset. So I guess adenosine is a good example. Adenosine has a 6-second half-life, right? It's like, oh, your SVT, take one of these pills every 6 seconds, right? So I'm gonna discharge you home, and every 6 seconds you got to take this. Otherwise, your heart rate will go get super fast, right? So that's an example of medication that's only IV push, right? Amiodarone is IV push and it's PO, right? There's a PO form as well. Same thing, digoxin. Digoxin can be IV push, digoxin can be PO, all right? What else? So you have an emergency, you have a patient seizing, right? You know, he's like, okay, get him on their side, okay, put a PO, let's get it in there, right? That's not going to work out, right? So IV push is necessary in emergencies, such as a seizure or a lethal arrhythmia, right? So what are some lethal arrhythmia IV push meds besides adenosine and amiodarone? So atropine would be one. What do you give atropine for? So bradyarrhythmias, right? And then we have, what other IV push cardiac meds are there? Epi is IV push. What else? There's some calcium blockers that are, such as verapamil, and diltiazem is usually more common. But yeah, diltiazem and verapamil. All right, what else? With IV push meds, you can't take it back. You can't, once you give it, you can't say, oh, no, stop, right? It's there, it's in, right? So as far as if you give it too fast, remember it's like every approximately 2 to 5 minutes, that's where it's going to be infused, right? That's usually the normal infusion. What if you give it like 10 seconds, like every nurse you've seen give an IV push for the last year? Well, then they're at risk for speed shock, right? So speed shock is where you have a surge response, right? We talked about surge response before. It's a systemic inflammatory response. It's an insult to the body, and it's like, what the heck is this? And the inflammatory cascade gets activated, and it's going to be a body-wide response, right? And that's going to cause you to feel crappy, like when you have a surge response when you get a vaccine. So you get you get malaise, you get you can get hypotensive if it's a significant surge response, right? It's a widespread vasodilation, widespread inflammatory cascade, and that triggers the SNS. So you can get tachycardia, tachypnea. You get vasodilation. Usually, when you have an SNS response, you get vasoconstriction, but the inflammation itself causes vasodilation. And they get flushing because of the vasodilation. They get a headache because of vasodilation. They get syncopal if the blood pressure is low enough, right? And their pulse is irregular, like slow, right? It could get slow or it could get fast, depends on what medication is. If you give IV push diltiazem, it's going to get slow, right? If you give IV push, atropine, it's not going to get slow, right? It's going to get fast, right? And those ones don't usually cause a speed shock. So speed shock is just giving an IV push medication too fast. It's a complication of IV push therapy, okay? And you can even get cardiac arrest if you give it too fast. Right? That's a danger. Okay, so speed shock is a complication. Normal medication side effects can happen. Right? So you give medication like digoxin, you can have what side effect with digoxin? Then you get nausea and vomiting. Right? The nausea and vomiting might be due to the bradycardia because of the poor cardiac output, but it could also be due to the medication being on board, and it has its own side effects with toxicity. Right? And then medication incompatibility. So the medication itself is not compatible with the other medications that are in the line. So you got to make sure the line is flushed between medication passes, right? All right, first step also is to make sure you have good IV access. Otherwise, I mean, the arm is going to get atropine. It's not going to hit the heart. So you have to make sure you have great IV access so that we can obtain or get a action out of the medication, right? So you can get ultrasound guided IV, right? That's usually a better, more secure access. Sometimes IV pushes have to be given centrally. What's a medication that's be given centrally, IV push? Technically, you know, sodium bicarb and calcium chloride should be given centrally. They are very, very have vesicant properties. They are damaging to the veins, right? All right, so what else? So if you don't have good access, you can have vascular complications like phlebitis or extravasation or vesicants, or vesicant damage from vesicants, such as calcium chloride or sodium bicarb or potassium. Should you give potassium IV push? No, that's one of the ones we're not going to give IV push, even as an RN, okay? But you need to have good IV access, otherwise what can happen? You can have all these complications here, so how do you avoid that? Gotta find Chad.
You need an IV? You need an IV? Hey, who needs an IV in here? Hi everyone, my name's Chad, I'm 26 years old, and I'm the unit super user of IVs. Woo! Vein finder? You mean these? Hard sticks? Oh, I just call them sticks because they're so damn easy. I think the IV team's gonna draft me pretty soon. You need help with the IV? Hey, you have a nursing student? I'm about to put in an IV. I only dropped 3 things. IVs, acid, and tantaran. It went in like butter, bro. Oh, you wanted to hear about my IV? Let me tell you about it. 2 steps. The first step is your form. If your form's not right, everything else is wrong. Your form has to be impeccable. Step 2 of putting an IV in, put it in. I got the IV in bed 5. I just took that needle, put it in, 45 degrees, got the flash. They call me Hawkeye, moved it to 15 degrees, back to 20 degrees, inserted in advance. They call me Katniss Everdeen, put it back out, and bam, put it back in. Bam, that's it. I just taught you how to put an IV. Thank me later. They call me Princess Merida, or just Princess for short. Ultrasound guided? I don't know her.
All right, so you have good IV access. Otherwise, what happens? You get extravasation and really bad outcomes.
You need an IV? You need an IV?
All right, so these are some IV push catastrophes where you did not check good IV access. All right, so you can have phlebitis, which means that the vein gets inflamed from the medication itself. All right, there could be bacterial complications, or you can have chemical erosion of the vein, and it can cause, the medication can leak out and cause further damage to the arm, right? That's a really bad compartment syndrome. So the vein the tissue swole so much that it had to be cut open at the bedside emergently. All right, so mechanical, right? Due to IV start, did you use an ultrasound to make sure it went in the right spot? Right, so you check IV patency. That's a good reason to know that you're in the right spot or not. And then vesicant necrosis. So some medications will damage the vein, and when they extravasate, it can cause even further damage. Right, chemotherapy drugs are not given IV push, but if they extravasate, it can be very, very bad. Right? So how do you fix it? Well, you have to slap the patient. All right, you have to use S for stopping the infusion. Right, we're going to prevent that necrosis from happening any further. We're going to leave the IV in place while we try to aspirate what medication is in there. We're going to then P, we're going to prepare an antidote because there's different antidotes for different medications. When we learn chemotherapy and oncology drugs, there's specific antidotes for each one. Usually the common denominator is hyaluronidase. So hyaluronidase goes through all the vessels and fascia, and it opens up the whole thing, and it allows the antidote to reach all those areas, right? So hyaluronidase really just breaks apart all the tissue and fascia. All right, so cold compresses, not ice. Ice can be damaging, but warm compresses usually are, depends on the medication too. Some medications need warmth, other ones you don't want them to get reabsorbed. You just want to control it locally. All right, so infiltration, what's an infiltration? That's when a non-vesicant leaves the vein, right? So you're giving sodium chloride and it infiltrated. If something extravasates, that is a medication left the vein, but it's a medication that is like one of these guys here, right? They have like potassium, for instance. You have a norepinephrine, vasopressors, the chemotherapy drugs. So these are drugs that will, actually over here, sorry. These are examples of medications that will cause damage to the hand or to the arm or to wherever the vein axis is, right? This usually happens with peripheral IVs. It's really hard to happen with central access, right? And oftentimes these happen because someone was lazy and they didn't want to put in a central line. So you need to put a central line with the osmolarity is super high, the pH is super low. Certain medications require central lines, otherwise these things happen. All right, so IV push prep. So before you get an IV push med, you have to know the 10 rights, right? When I was in school, it was the 6 rights. So it's there's like 30 rights now, but this is a good one, a MICTE turd. All right, so it's to know you got the right medication, the right client, the right dose, the right time, route, documentation. That's a good framework to start as far as the right given the IV push medication. All right, you want to know the generic name because sometimes they'll say, oh, you want to make sure the brand name and the generic name are lined up. You know this is a proton pump inhibitor, and this is what I expect to happen, right? You want to know the drug class, you know what you're giving. If you're giving a BP med or an antiarrhythmic or a anti-ulcer medication, you want to know which one's which. Know why they're getting it. Don't just give it because it's ordered. That's the worst answer, right? And you have to get why they're giving it. And is it safe to give? Did I check my electrolytes? Did I check my H&H? Did I check these things? Okay. Is it an appropriate dose? What rate will you be given to that? So how fast can I give it, right? And usually when you're instructed in how to give IV push meds, you're giving it over a 15-second interval. So you're solving for 15 seconds, right? So you're not solving for mLs per hour. That's what you program where? In the pump. So you're programming mLs per minute. You're programming mLs per 15 seconds, right? How many mLs over how many seconds? So you're trying, and again, 15 seconds. Do I need a diluent to make it an easier amount? Because it might say give 0.23 over 1 minute. So how am I going to do that? That's divided by 4. That's 4 15 seconds. So 0.23 divided by 4. I'm going to give them 0.06. What am I doing here? How am I going to do that on a syringe, right? So you can dilute it currently. Technically, you're not supposed to dilute anything, right? But currently what we're teaching you right now is you can dilute it. Both hospitals right now practice that way where you can dilute it. Technically, everything should be done through pharmacy, and they deliver it to you, and you give it per the pharmacy instructions. There's no risk outside of, no risk of complications, no risk of, like speed shock. Like you're going to 0.23, so oops, I gave it, right? It's really hard to manage that. All right, know what to monitor, know what the heart rate is, know what the blood pressure is, know what what your labs are. Know onset peak duration. So this is what you're getting tested on with IV push checkoffs. All right, usually IV push meds are 15 minutes as a ballpark, right? And patient teaching, give at least 2 tips about why you're giving this medication, right? Your syringe should be labeled with what you're giving, all right? If you're giving 2 IV push, you should label the first one before drawing the second. You're not going to draw your protonics, draw your methylprednisolone, and draw your digoxin. And I forgot which one's which, right? You want to make sure you label it after you draw it in between each step, right? And don't throw away the drug vial because oftentimes you have to scan that drug vial into the computer, okay? So milligrams per minute is used to find your mLs per 15 seconds because usually they'll say only give this medication over 5 minutes, or only give 40 milligrams per 3 minutes. Lasix, for instance, furosemide says max of 20 milligrams per minute. That's as fast as I can give it. And that's the important thing you're trying to identify. So like when we talk about math in general, we're trying to find concentrations, we're trying to find volumes, and then we can go from there. When you're doing IV push, you have to find the milligrams per minute. How fast can this medication go into the body, right? Because it can be diluted, it can come in different concentrations, right? You might get a vial of heparin that's 5,000 per cc or 1,000 per cc. I need to know how many units per minute can I give this medication, right? So I don't need to know the mLs per minute. I'm going to calculate that afterwards. Once I figure out the safe dose that I can give per minute, then I can figure out the concentration I have, and then I can figure out how fast I'm going to give it over each 15-second interval. And I might have to dilute it, right? So for instance, if it's 20 milligrams a minute, and it's a Lasix vial of, let's say, 40 milligrams, right? I'm giving 40 milligrams. How fast can I give it? It's 40 milligrams per, let's say, 4 mLs. It's a vial of 4 mLs of 40 milligrams of Lasix. I'm giving 40 milligrams. How fast can I give it? So if you think about it, it's 20 milligrams a minute. I can only give half the dose in the first minute and the next half the dose the next minute. So that's 4 mLs over 2 minutes, right? So 4 mLs over 2 minutes is 2 mLs a minute divided by 4 is what? 0.5. So 0.5 mLs every 15 seconds is what I'm going to be eyeballing when I give this medication, right? So you could do mental math like that, or you can write it out. It's going to make sense either way, right? So you'll get there. So that's the idea, is to figure out the milligrams per minute first, and then look at your concentrations and the dose that you're giving. Test, 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 test. Looks like it's working. All right, so administration of IV push medications, right? So we don't make sure we know how fast it's going. Make sure you can give it as slow as you like. Technically, right? At a certain point, you're going to lose the efficacy of the medication. It's going to wear. You want to make sure you have it instilling the patient at a certain speed. But technically, you can give it as fast as as slow as you need. Like not like 30 minutes to an hour, but 5 minutes, 10 minutes, 4 minutes, 3 minutes. That's perfectly fine, right? If it says give 20 milligrams a minute and you're giving 20 milligrams, you could give 20 milligrams over 2 minutes currently, right? Until both hospitals actually update themselves to the 2018 recommendations, then we'll talk from there. All right. By the way, we want to make sure we have good IV access. We're going to flush the line, because if it's not flushed, you can get compatibility issues, right? You get precipitation and crystallization of your IV. There used to be charts that you could compare and contrast to, but now you just look in Micromedics or a IV checker to make sure that the medications are compatible or not. Okay, so if you're doing a central line, you want to make sure you're flushing at least 10 mLs after your medication. Usually the mnemonic we tell patients that have like portacaths or a central line when they're going home and they're giving their medications, it's called a SASH method. You're going to saline flush, you're going to administer your medication, you're going to saline flush again, and then only heparinize if they have a port or a line that requires heparinization. What line requires heparinization? Which central line? Portacaths and Vascaths, they would not be administered at home, but yes, Vascaths do get heparinized. It's a Broviac, right? A Broviac catheter, if they have one. All right, but usually saline is just adequate nowadays for like a PICC line, or they would likely go home with. Okay, all right. So incompatible meds, they might be incompatible because it's a calcium and phosphate. Those like to bind with each other. Glucose and Dilantin like to bind with each other, so we're going to avoid that. All right. Sometimes medication might be inactivated because of the pH of the line. Like you have a bicarb infusion, a bicarb drip going, that's going to inactivate every medication pretty much. That's going to hit that line. All right. There's very few that are compatible with bicarb, for instance. Okay. So there might be some medications that when the two drugs are together in the same line, they might inactivate each other. So we have to make sure we are between medications, we are flushing. All right, so yeah, so it's a push-pause method. So it's just like Lamaze.
So 15 seconds, and then he will connect his saline syringe. And still the same push-pause type flushing as central lines. 1 to 2 cc's, short break, 1 to 2 cc's. So you create the turbulence even in the peripheral line. He would finish his flush, and then as he disconnects, you can see a small squirt of fluid off the end of the catheter, which is your positive displacement. That fluid keeps blood from backing into the line.
All right, so next slide, please. All right, so as far as not all IV tubings are created equal, so when you give your medication, it may just all be in the tubing. So if you're giving those 4 mLs of that's a bad example, but it's like you're giving, let's say it is 4 mLs, right? When you push it right here, 2 mLs will still be in the tubing. If you look at the manufacturers, this one says 3 mLs, this one says 1.3 mLs. So in the extension set, your medication is still going to be there. So you have to flush it afterwards, right? And also by the same token, there's saline in there ahead of time, you'll see students, which is okay because you're new to it, but you're flushing super slow at the beginning. I mean, you got 1.3 cc's of leeway at least to flush in that medication into the line, and then you start slow. But what's most important is afterwards, you'll see the students go to slam it in. It's like, why'd you spend all the time to put 1.3 cc's in there, and you're giving a 2 cc dose, and then you're going to slam in the flush to flush the medication all the way through. All right, so it's to chase it, you need to chase it at the same rate you calculated before. So if you're doing the 0.5 cc's every 15 seconds, you can do the same thing with the flush afterwards, so that the whole line is flushed, right? Because you can't give IV pushes at different points. You can give it here, just below the Laris pump, below the channel. You can give it here, which is just distal to the, or just proximal to the Y set. You can give it on the other Y set over here, right? And you can be, you can raw dog it, and you can just go ahead and disconnect and give it IV push right there at the hub if you wanted to. All right, but either way, we have options. Okay, so what else? So yeah, when you give your medication, sometimes you're like giving like 0.63 cc's, and is that really going to reach the patient? Yeah, I'm going to put it in the tubing and then I'm going to flush it. Really, the best practice is to program your IV pump. Right, this is not what should be checked off on, but you should put the medication in the tubing. So it's like right here, for instance. We're going to put the IV push medication in the tubing. So this is the patient over here, right? I'm going to put the medication in the tubing, so it's right there, 3 cc's or so. And then I'm going to program the pump at a safe rate to deliver it perfectly at whatever rate I calculated, right? That's ideal, right? But we're trying to, but right now you're doing because not every patient has IV tubing hooked up and saline and fluids infusing. So you have to, so sometimes some patients are just saline locked. And at that point, you do have to use the certain mLs over 15 seconds, right? But if they have a pump and they have fluids running, go ahead and put it in the pump and the tubing, and let the tubing do the work for you. But in nursing school, you're going to be checked off on so that you know how to do it, just in case you come to the worst case scenario, right? What else? So the flushing the line is where it matters most, right? And usually your default rate will be 75 mLs an hour, right? So 75 mLs an hour is your default rate. Let's erase that. And that is just to maintain a certain flush behind the medication. So you give the medication, and when you give the medication via tubing, you're supposed to kink the tubing right here, right? So you kink the tubing and you give that medication at the rate you calculated, and then you unkink it and let the pump start flushing it in, right? So that's how you're going to be taught when you have two methods: one with IVs infusing, and of course it needs to be compatible, and then one without, where you're just saline locked, where you're just giving it via a saline lock. Okay, so what else on this? So for instance, is 75 should that always be the number? Well, if it says 20 milligrams a minute, right? 75 milligrams, 75 mils an hour is what you're going to program the pump to flush. But we have Lasix at 20 milligrams a minute. You're giving 40 milligrams. That's 10 milligrams for every minute, right? Or that's 10 milligrams an ml, and you're giving 20 milligrams a minute, that's 10 milligrams a minute, right? So what rate is that if you're giving 10 milligrams a minute in mLs per hour? Do you follow? So if I need to give this medication 40 milligrams, right? The max is 20 milligrams a minute. So, and I'm pulling up how many cc's? 4 mLs, right? And I'm doing 20 milligrams a minute. I'm giving 2 cc's every minute. What rate is that? So really the IV pump should be what? I think I put the wrong number up there, but to demonstrate the example. But anyways, you could program into the IV pump the mLs per hour. If you know the mLs per minute, you just multiply by 60, right? Because if that's the milligrams, that's the mLs I'm giving in this minute. If I have 60 minutes an hour, that's going to be times 60. Okay, so I'll relook at that one. Anyways, you want to make sure that the IV pump is at least 75, but sometimes it might be less. Okay, I think what I meant was you're giving 20 milligrams or something. Either way. Yes, I'm saying I was trying to give an example of when it's lower. All right, so I'll redo that slide. Anyways, IV push procedure. That's not going to be tested on everything. That's just something. Anyways, IV push procedure. It can either be given with an IV pump or it can be given with a saline lock, right? So in blue here is the method with an IV pump. That's where it's different, right? So first you can check your vital signs, your allergies, whether it's patent, your IV's patent, right? If it's IV fluids are infusing, you got to make sure the IV fluids you're going to give this medication with are compatible, right? So calculate the amount of med to give with every 15 seconds. So you do math to figure out what that's going to be, right? You're going to swab the lowest port, most proximal. The ideal is just closest to the patient if you can. Otherwise, you're going to scrub the hub, right? Hub every single time. And then insert the syringe into the port, and you're going to, if it's IV fluids, you're going to reduce or increase the rate to 75. And if it's just staying locked, all you're going to do is make sure you got it flushed. You already did that ahead of time because we already hooked it up, right? We're going to be then making sure that we administer safely. And we administer, it's going to be over 15 seconds each little dose that we're doing, right? And if it's just straight into the saline lock, you're just going to give it nice and slow continuously. If it's via IV pump, what they want you to do is calculate what you do over 15 seconds, but give it over 10. And for the last 5 seconds of that 15-second interval, you're going to unkink the line and let it flush. It's called pinch, push, pause. It's a little bit confusing, but you have to. It's so the pump's not alarming at you the whole time. You got to give it a second to start flushing. Otherwise, it's going to alarm you. You're going to be going back and forth, silencing the pump, right? So if you calculate it, we're giving 0.5 mLs over 15 seconds. Instead, you're going to give 0.5 mLs over 10 seconds, and then let the pump flush for 5 seconds. So when you're done, you got to flush at what rate? The same rate you calculated. So that you're still going to flush the IV tubing at the same rate you calculated for the medication itself. Okay. So you got to pinch, push, pause for which method? IV push or saline lock? This is for IV push. This when you're going directly in. They were meant business. They took the hub off also. All right, they're not messing around. All right. Anyways, this one that's IV tubing, so we're pinching it, right? And you got to make sure you're checking patency, right? So it's patent. Yeah. So E makes the valve say its name, so it's patency. All right. So these are the INS ISMP statements. All right. So this is again, these are things that are going to change eventually. Right, but we don't know when they're going to change, when both hospitals will update their policies, but they need to, technically you're not supposed to be preparing this at the bedside. Technically you're not supposed to be diluting it at all. You're not supposed to be adjusting anything. It should be pharmacy prepped sterilely so that you're not making things up at the bedside. It reduces errors, right? But we still are disinfecting, we're still assessing for contraindications, we're still doing those things. But those things in yellow, just as FYI, these things are to come. So the IV push meds you have to know for the test. And these are the real ones. So you have to know these 6 right here. Okay? So those 6 are the big ones you got to know. You got to know them inside and out. All right? Try to make a table if you can. We got to add in onset peak duration, right? We got to know that, what we're going to monitor, what the nurse considerations are. And I have a sample table you can take and adjust. And each one of you guys can have a study group. You take 2 each. If you have a 3-person study group, or I don't know, split it as evenly as possible. That way you have something that you've made and you've compiled from the different drug guides and different recommendations, right? For the test for exam 1, you have to know the cardiac and GI meds. You have to know you can't give IV push narcotics. You have to know you can't give IV push. What else? No IV push KCL either. Okay. All right, so the last slide is math. So basically, when you calculate, you'll be doing this math on your own. You have to present the math before you get checked off and get your little practice doses in the lab. But you have to calculate the dosage over 15 seconds, all right? And to get there, you can use dimensional analysis, right, to figure out, okay, I can only give it so fast, right? Like Lasix, we said, is 20 milligrams a minute, right? This one, we looked up this medication. This is just an example. It says 2 grams in 2 minutes. That's how fast I can give this medication. Now, what medication do I have on hand? So that's what you're looking at, your concentration. What's the, that's what and then of course what the dose is. So I can only give it this fast. This is the dose I'm giving. Sorry, this is the concentration I have on hand, and this is the dose I want to give. And this dose I want to give over 15-second intervals, right? So this is the math that will, it's the shortcut that'll get you there, right? So you get that's all in one step. So sometimes you'll get a weird number like 0.63. And you can't give 0.63 over 2 minutes or 3 minutes. How are you doing that, right? 0.63 over 3 minutes, that's 4 15 seconds for each minute, right? So that's 0.63 divided by 12, right? So we're giving like 0.12 every it's not gonna work. So anyways, sometimes you have to dilute it. And yes, you can dilute it currently. All right, so to dilute it, you can do algebra, you can do trial and error to get you there. So I got 3 different methods you can use to solve for how to dilute it to make it easy, right? You can do mental math. So if I'm giving, for instance, I calculated that I'm giving, I don't know, let's do something weird, like 0.5 over 2 minutes, right? 0.5 over 2 minutes is what? What for every 15 seconds? Remember, there's 4 15 seconds in every minute, right? So if there's 4 15 seconds every minute, if 0.5 over 2 minutes, that's 0.5 divided by 8. What is 0.5 divided by 8? Yeah, how are you going to push 0.0625 every 15 seconds? I mean, the syringes don't even go that small. Because the littlest one is 0.1, right? So, but I can do 0.1. So what is 0.0625, or what is 0.1 minus 0.0625? Point what? 0.0375. So if I multiply that 8 by 8, that's how much I need to dilute, right? Because I'm going to add that little mLs for every little 15 seconds. I want to do 0.1 every 15 seconds. So if it's 0.0625 every 15 seconds, I can add that amount times 8. Right? That's the mental math. If that doesn't work for you, you can do trial and error, right? So I don't want to do 0.5, I want to do 4. Right? But then you have to figure it out. Oh, 4 doesn't divide nicely, or this one doesn't divide nicely. So you can do it trial and error. You can just punch different numbers in here to figure it out dimensional analysis wise. Or if you're fancy, you can do X. You can solve for X. Okay, so that's that idea. So this example gave you a 2 gram dose, right, of drug X. I need to give 2 grams. It's safe to give 2 grams over 2 minutes, right? That's my safe dose. I can't go any faster than that. I can go slower, but I can't go faster. Right? So look at the concentration of the vial. So the vial says how many mLs I'm giving, and that's going to tell me how fast I can give it, right? So I'm going to get a number out of that. So it says what? So 2 grams per dose, I can give, again, how much? I'm giving 10 mLs, or sorry, it's 10 mLs. 2 grams is in 10 mLs, right? So I put 10 mLs into this medication right here, and I pull out 2 grams. And I can give 2 grams, and how fast can I give it? 2 grams in 2 minutes. So that's 10 mLs in 2 minutes, right? And 2 minutes is 8 15-second intervals. So 10 divided by 8 is 1.25. I did the math already, right? So 1.25 mLs every 15 seconds. Now, if I wanted to make that even, I want to do 2 mLs every 15 seconds. That's super easy. Can I do 1 mL every 15 seconds? That'd be even easier, right? Can I do that? No, that'd be too fast, right? Because we said that is only 2 grams in 2 minutes. 2 grams in 2 minutes, or 10 mLs, which is 2 grams in 2 minutes, is 0.5, what did we say, 1.25 every 15 seconds. If I do 1 mL, that's faster than 2 grams in 2 minutes, right? So I have to go up to 2, or I can do 1.5 if I wanted to. I just have to make it whatever I like, right? Current practice, right? Does that make sense? So again, you can use these 3 methods to get there, to figure out how much do I have to dilute to make it like 2 mLs every 15 seconds. All right, I want to give 2 mLs every 15 seconds. How much do I have to dilute it to figure it out? Or I can do dimensional analysis and try to input 2 mLs in there to figure out how much I'm going to give every 15 seconds. Okay, so there's different ways to figure it out, but it'll get you there. All right, you just can't go faster. You have to, again, the key thing is what's the safe rate of that medication. What's the concentration? Because the concentration can change. If it was 2 grams of 5 mLs, that'd be 5 mLs over 2 minutes, right? That's 2 grams in that 5 mLs that I'm giving over 2 minutes, right? I don't know why I chose 5, but 5 divided by 8 is what? 5/8? 1/8 is what? 0.125? 0.125 times, what is it? So I do 5 mLs divided by 4, divided by 8 is what? Point what? 0.625, that's ridiculous. I can't give 0.625 of medication, right? It only goes to maybe about 0.1s. All right, so if I want to do 0.625 and I want to go up to like, maybe I want to do 1 ml, or sorry, I want to do 1 ml, not 0.625 mLs, right? I want to do 1 ml every 15 minutes, sorry, every 15 seconds. Then I can add the difference times 8. All right, that's the mental math way, or you can just solve for it. I want to give 1 ml, so I'm going to mess with the dimensional analysis to figure it out. All right, does that make sense? Sort of? Okay, so that's the checkoff you have to do. And again, the checkoff is the week after the final. So really don't have to stress too much about diluting and such, but final after the first exam. Okay, so that week in clinical, you do the IV push checkoffs, right? For the test, you have to know the previous slides. Okay, this is for the IV push checkoff to hopefully help you. Was your question?
This would be on the first exam too, right?
This math, no, would not be. Now, this is it's supposed to help you for the checkoff. Okay. All right.